And a warm welcome, as always, to Dr. Eamonn Shanahan, who's here in studio with us. And Eamon, you brought a special guest with you.
I did indeed. So I'm delighted to introduce again Mr. Mohamed Taha, who is a consultant urologist at the Secours Hospital, Tralee. We were just saying off air before he came in that he's here 3 years plus in Kerry now at this stage. And he has been with us before a couple of years ago, but he's come back to very kindly talk to us again.
Very good. And you're very welcome, Dr. Taha.
Thank you so much for the opportunity again. It's actually very nice to get the chance to speak to Kerry people about our services and our medicine. Very pleasure. Thank you so much.
Great stuff. And Eamon, we're kind of, how will I put it, we're framing our discussion today around urology, which is everything to do with the bladder and the
kidneys. And especially the prostate and that kind of stuff. So I suppose for me as GP, one of the things that I would see from time to time, and we actually encountered this a couple of months ago, a man came into me early in January who had blood in his urine, and he was very concerned about this. Now it was bright red blood, and this sometimes happens. So just before that, Mr. Taha had just started a new clinic in the Bonds, what they call a rapid access hematuria clinic. So hematuria is the medical jargon word for blood in the urine. So the thing is, I was delighted to be able to refer this man on. Obviously and understandably, if anybody, man or woman, sees blood in their urine, they will get concerned, and especially if there's a lot of bright red blood. And it's being able to appropriately investigate, treat, and then appropriately assure the person. So that's what Mr. Taha did for me.
Very good. And so let's, before we talk about the clinic, Dr. Taha, let's talk about blood in the urine. What might that be a sign of?
So initially I have to give Dr. Shannon the credit of sending the first case for the rapid access prostate hematuria clinic. Overall, the rapid access clinic is a clinic pathway had been made to make the patient get quick access for clinical assessment and subsequent workup. Blood in the urine, or hematuria, as Dr. Shannon said, explained earlier, is blood in the urine mean bleeding from somewhere throughout the urine pathway, starting from the kidney downward. And to be more specific, it's 2 types. One of them will be the patient seeing himself in the urine, and that where most of the patient get panic and come over straight away for review. But the other ones is actually macroscopically detected. Both of them, they carry in very small percentage, only 5 to 10% chances of cancer. But the people become panic about this small percentage more than the commonest, which is infections and other things. So they need to have workup, which is clearly constructed workup plans and pathways to find out the answer why they are bleeding. That's in summary what we tried.
And why was the clinic opened up? Was it a need? Did you see the need for it in Kerry?
Yeah, the rapid access clinic as a philosophy for service presentation is something known for years, and it is one of the 2 commonest clinic pathways in worldwide in the urology service. I admitted that here because I noted that the patient get delayed from the referral, and I wanted to have a framework. I think most of the patients get very reassured when they come over and they know they're going to be seen in 3 days, get the first assessment within 2 days, and final diagnosis within 2 weeks' time, which is very short period really to get out of the dilemma what's happening. So looking into my initial clinical services in Kerry, I felt there is a large number of patients need to have this kind of concentration and clear pathway, for which we started in January.
In January. And what has the response been like? Have you been busy?
It's actually great. Up to now is 200 patients at least we have seen between the 2 clinic, prostate and hematuria. And one of the important stories that I all the time mention is the first 2 or 3 patients we diagnosed a very advanced cancer in their bladder within 3 days' time. They were so delighted and happy with how quickly the things happens, and that was reassuring for all of us really. In the hospital too.
I think one of the biggest problems is uncertainty. That's the real killer. It's people not knowing. I suppose the point that Mr. Taha was making is that previously we referred to the clinic and the appointment would work its way through the normal channels, whereas with this it's literally in the name, it's a rapid access clinic.
Absolutely.
Okay.
Blood in the urine is a problem in urology for years really. If I want to flag it for the people, reassuring them, the commonest cause of blood in the urine is infections. So the people have to kind of take that a bit down from their anxiousness, but they need work.
I think one of the things, again, and it was a word that Mr. Taha mentioned in passing about what we call microscopic hematuria. So what that means is that there are a number of people who come into us, and when people bring their samples of urine with them, you look at it, you might see it be a bit slightly cloudy, but when we put these urine dipsticks in it, we'll see traces of blood in the urine. That's what he's talking about, that there is urine, there's blood present in the urine, but in such small amounts, such microscopic amount, it's not obvious obvious to the naked eye what is present within the urine. So there are a lot more people who have traces of blood in their urine, and it's only when we check their urine in our surgeries that we find we have signs of it. Now, as Mr. Taha quite rightly said, especially if there are also associated symptoms of an infection, then we, the GPs, will treat the infection appropriately, and if the problem goes away and we check the urine is clear, that's grand. There's nothing to be concerned about. But if the traces of blood persist in the urine, that's the reason why we might send them over to Mr. Taha and his urology colleagues for further follow-up.
So, Mr. Taha, most of the time, if people have a urinary tract infection or a kidney infection, their GP can probably help them with antibiotics and they don't need to go any further. But can you describe some scenarios in which they might need to see you, they might need to be referred to yourself?
So, as Dr. Shanahan nicely summarized at the beginning, 2 types of blood in the urine: either the patient see themselves the blood in the urine, or detected by microscope or by the test. The first one, which the patient see, we have a certain cutoff age group, which is 45 and above. If there is symptoms of infections, the GP will treat both of them anyway. And if it's recur or persistent, or the patient or the GP felt there is a high risk factor, we call them, over 45, smoking history, family history of other cancers in the kidney or the bladder, they come to us straight away, even before they complete the treatment of what we thought is UTI. Regarding the blood in the urine, if the patient had no symptoms, the GPs repeat the urine for blood in 2 weeks' time, and if it's still there, they send them over to us, what we call by persistent blood in the urine. If they do have symptoms, again, they follow the same pathway of the first one. Get treated from UTI first, repeat the urine test again, clear, happy days; not clear, they come to see us.
Yeah. One of the emerging issues for me as a GP is that we're seeing the emergence of what we call resistant infection. It's a serious concern. Our problem is that somebody gets treated with an appropriate antibiotic for the urinary tract infection, and it still is urinary tract infection, but the bacteria are resistant to the antibiotic. In other words, the antibiotic won't work, and we might have to go to second or third line antibiotics. And in those cases, because the other team, if you like, that Mr. Taha can bring on board with our microbiology colleagues, who can then advise what would be the correct antibiotics. I know I certainly had one lady who has since gone to her ward, and the only way eventually, and she was exceptional, but the only way eventually she could have her urinary tract infections was by intravenous antibiotics in hospital. And it rarely happens, and it's kind of one of the things we're trying to avoid happening, and encouraging people not to abuse antibiotics, but that's a whole different day's work.
So in addition to people who might actually have something serious like bladder cancer, kidney cancer or whatever, what other conditions do you treat typically?
So I will be saying from the start to the end, start from the kidneys down all the way to the bladder. That's where the urine passes through. We can have infections, we can have inflammatory conditions, which are a kind of inflammation, mean immunity of the body start to react against the body tissues. Can happen for any other reason, not necessarily infection. We have a stone disease. Patient can form stones in the kidney or the ureter or the bladder. And then we can have the cancer by different types that we mentioned earlier. These are more or less the common causes. Having said that, there is a long list also of medical causes that can cause blood in the urine, and this usually taken care of by the nephrologist, which are the medical side of the kidney, like glomerulonephritis and other infections. This is why when I take patient for workup for blood in the urine, if I find all my workup urologically negative, I advise them to go to see a nephrologist, because they have different way of investigation to find out, do they have a medical disease that cause you to bleed or not. To make the picture a bit clear, a bit more to the people hear us, when you get a medical cause of blood, sometimes you can progress to kidney failure. So they need to see you a bit early to prevent that or to treat it.
Okay. Do you see, I just know from doing the medical slot regularly, that a lot of women in particular seem to have bladder problems and overactive bladder problems as they get older. Do you see them? Yeah,
so the overactive bladder is the very common terminology we use to describe I don't want to go to the medical definition, but it is mainly patient feeling that he is passing urine more frequent, or she, more than other people around them, mainly during the day or the night time. I believe the ladies have more risk factor to develop what we call by weakness of the pelvic floor muscles, which are found to be, theoretically speaking, now risk factor to develop an overactive bladder. That will come from pregnancy, from changes with labor, and also from the estrogenic or hormonal status around the genital area and the pelvis. That, I believe, is most likely proposing them for overactive bladder as a conditions. Yeah.
Okay, and it's more likely to occur as you get older.
Well, I'm not going to use the word recur, but I will be saying it commonly to progress, because the more you get older in age, in ladies you get more hormonal deprivations because they lose estrogen hormonal status, and the more they get the pelvic floor more weaker because there is no more activity, if you like me saying. But that is progression more than recurrence. But overactive bladder can happen in age, including children, by the way.
Okay. Do some people, Dr. Taha, have smaller bladders than others? Because with women, some women seem to need to urinate a lot and others don't.
Yeah, so to make that a bit more clear, I will go a bit backward from what we arrived now. The bladder's functions easily can be divided into two. The bladder need to store the urine until you're happy to pass urine, and then help in pushing the urine out. The storage part of the bladder is mainly maintained by two factors. The muscle of the bladder have to relax to give the volume of elasticity for the urine volume to take place. So the bladder will become wider and wider and wider. And the second part of the storage part is the sphincter have to be tightly closed.
The sphincter.
The sphincter, which is the muscle surrounding the opening of the bladder. These two have to be happening together to give the storage phase of the urinations. In the overactive bladder symptoms, if you have disturbance of one of these two or the two together, you develop symptoms that called by, we don't say it as overactive bladder, we call it by storage symptoms.
What's that again?
Storage symptoms.
Storage symptoms.
And to make it easy for the patient as well, they are passing urine a bit more frequent during the day, during the night. They get very bad urgency to pass urine. They can't inhibit it. They have to go. Our body had been naturally created that you can control your desire to urinate. You can delay it. But with these patients of these symptoms, they can delay that, as well as sometimes they urinate or they leak urine on the way to pass urine. We call all these as the storage symptoms for the urinations. They have different causes. One of them is overactive bladder. Now, going back to your questions about the small bladder volume, if you think about what I described now, if the bladder is unable to distend to accommodate for the urine accumulation that happen over time, should be small, so the patient have to go quickly to pee again. So he lost the elasticity, which is very important part of the bladder to store the urine. That is in simple way. But not all overactive bladder patients have a small bladder. They sometimes have a normal bladder capacity, no problem.
Irritable.
But the bladder contractions is overstimulated.
Yeah.
Overstimulated.
Okay, there's a lot to take in. We're going to have to take a break, but we've lots of questions for you, and we'll come to those after the break. And just to remind listeners, 083 300 3300 if you have a question about anything to do with the whole urinary system. Consultant urologist Dr. Mohamed Taha is here in studio with us, and Dr. Eamonn is here as always. Do get the questions in, and we'll be back with more medical matters in just a moment. Well, we got a lot of questions as expected for Dr. Taha, so we'll start with this one. It's a lady in her 80s who is getting repeated urinary tract infections. Is there anything the doctor can suggest that might help her with this, or is it just antibiotics?
So the simple answer would be come to see me, but the breakdown of that is the first step on this scenario is for me to confirm that the symptoms were actually infection, not something else, because this is actually the initial pathway. And if you start the pathway wrong, you can come back. But if she had confirmed infections before, there is a lot of advices we give to the patient to start with. In our age, I like to give what we call by natural protocols and personal hygienes to improve that. I start usually with good hydrations. We're very bad in drinking water in Ireland, unfortunately. And I all the time say to them, how much water do you drink per day? Oh, I drink 1 or 2 cups. That's not more than 700 cc a day. We should aim for about 1 to 1.5 liter at least. And in hot weather, you can go for 2 liter at least. And then you should avoid constipations. That's very important as well. And then finally, we can go for hormonal replacement for a lady in her age. We give local estrogen replacement, as well as other advices like taking cranberry tablets. Apparently, if there is an infection that needs to be treated, it has to be treated first before we speak about prevention. Now, we do work up for the recurrent infections. That's what most of the GP centers, they treat the infection first time, but the recurrent one is what need to be treated, sent over to us. And the definition of that is an infection in the urine over 3 times in 6 months' time. That is the definition the GPs use. And then that will be recurrent infection. They come to us for a lot of workup and other investigations.
So you would be able to give her some advice?
Absolutely, yes.
Absolutely. She'd have to be referred by her doctor, obviously.
Yeah, absolutely. Yeah.
A caller in her late 50s says she has a very strong smell from her urine. What could this be?
It actually, I had a patient who had been seen us looking for very urgent appointment because he think he had infection, and that was the complaint. Now, the urine is a drainage of a waste product. So whatever we drink and metabolize in the body have to come out. So it can be as simple as something related to what you drink or eat during the last few hours before. So we don't take really the smell of the urine as indicator for infections. It has a very weak really weight in diagnosing or treating infections whatsoever. So my advice for her will be go to the GP, check the urine microscopically to confirm you have an infection or not, in addition to the clinical assessment. And if there is, she will get treated. Going back to the point of hydrations again, high water intake will prevent that too. Improve the smell.
I think an important point just there in terms of bringing samples of urine to the GP, ideally bring them in a clean container, ideally drop them over in the morning if possible. We will check the urine ourselves, we have dipsticks to check it, but ideally we'd like to send the sample to the laboratory. The reason being that the laboratory will actually look under a microscope, see whether or not there are bacteria present, and furthermore that they will then check to see what the antibiotic, if there is an infection present, what the infection is and what antibiotic is going to work best, because we need to target the antibiotic at the particular problem the person has or the bacteria that the person has.
But this lady in her 50s, there might be nothing. It could be just something she ate.
Yeah, that's exactly the point.
So she should ignore the smell and just test the urine first.
Okay. Sure, now, our next caller has a 12-year-old daughter who's in a swimming club. About a week ago, she did an intense session, about 80 litres or 80 lengths of a 25-metre pool. That evening, she had little spatters of blood in the toilet when she urinated, and the same the next day. She had no other symptoms like a fever or infection, none of that, and she hasn't started her periods yet. So the mom is wondering, what could this be?
So the difficulty in this scenario is to tell where exactly the source of the blood is. Is it with the urine or from the genital area or vagina speaking? That needs to be clarified first. If it is from the urine, again, we have to test the urine first microscopically to be sure there is no infections, and she needs to have a further workup to know if there is any other source of bleeding. In her age, it does have a very light weight really regarding serious problem, but it needs workup.
Yes, she probably should go to her doctor.
Absolutely, yeah, that need to be reviewed, no doubt.
I think she was trying to see if there was a connection with the hard swimming.
The exercise.
Yeah.
I think it's not so much extra swimming itself, but probably just the extreme exercise that the girl did, whatever, 80 lengths, to be fair. Now, the answer is maybe.
Yeah, we do have something called by stress hematuria, which is related to excessive physical exercises, which is blood in the urine from exercise, as you mentioned earlier. That can happen too, but you can't be sure until you rule out other causes.
And here's an interesting one from a Listowel caller. His brother, who's in his 50s, has prostate cancer, and his late father had it too, and now he has prostate problems. So that's him, his brother and his dad. He said, I read in the newspaper recently that the HSE won't make available a game-changing drug called Pluvicto,
Okay.
To treat prostate cancer. Would Dr. Eamonn and Dr. Taha have any comment on this?
See, if I can jump in there, the answer is, firstly, I'm not familiar with this particular product. Secondly, the issue there is that there is a process that goes on at a national level all the time. There are a number of products that come forward that are recommended for treatment. The difficulty is, and unfortunately I tend to be a bit cynical about this, who has determined that this is a game changer? Unfortunately, it's often the manufacturers are the ones who are considering this as the quote-unquote game changer. We need hard evidence to show that they actually do make a difference, and in fact that the cost benefit, I'm talking in terms of the cost to the person, because without shadow of doubt, every single drug carries with it the risk of side effects. And does the potential risk to a person from any drug outweigh any potential advantage that's there? Now, I think there's a separate issue there, the fact that there is a strong family history, and that's a really important point in terms of screening for and looking for prostate cancer. If there's a family history of prostate cancer, then we need to have a much greater awareness of the possibility of prostate cancer. We'll be checking for prostate cancer at a younger age in a man where there's a strong family history like that.
Our advice is now for screening is for men with the first degree relative of prostate cancer, they should go or start their checking up of their blood for the prostate in age of 40 and above.
40 and above.
If you are of the general population 50 and above, I think that would be the most message I would be saying to him about what he mentioned from your questions. Regarding the drugs, I didn't hear about it really as well. But one of the difficulty of prostate cancer is very dynamic, regularly changing disease. Every hour there is progression and changes. But we don't spread our management according to what is up to date. It according to what had been supported with good evidence to be used, and that will take a while before it comes to the field to be approved. Yes, the health policies about approval of certain medication nationally, it goes to a lot of things: availability, cost effectiveness, safety, and all of that stuff. So that will be something you have to be considered. But
it's not as straightforward as the article in the Examiner might have suggested.
Absolutely, yeah.
A lady in her late 70s says she has had a number of urinary tract infections and she doesn't always make it to the toilet on time. That's an issue, isn't it?
That's urgency straight away.
Urgency.
And again, I will be going back to the same all the time. See this question: starting the assessment wrong, we continue wrong. We need to confirm if that's an infection or that is an overactive bladder. This is the urgency that I just mentioned earlier, that the patient cannot hold. In other way around, the heart bladder is not happy to keep the urine stored longer than what the bladder wants, rather than following the patient desire of waiting until the situation is preferable for bladder emptying. Yeah.
I mean, the difficulty here is that if once the bladder starts to contract, for some people it can be very difficult for them to suppress the urge, and then if the valve is also not very strong, then what will happen is they'll leak urine, and it's just a horrible dose.
Caller says, can the doctor talk about bladder calcification, which was picked up on an X-ray? Is it something to be worried about? And she's a lady in her 60s.
So calcification in the bladder is dependent on the location of it. Before I become it, if it is inside the lumen, it can be bladder stone, and if it is in the wall of the bladder, it can be anything else. So for the calcification inside the lumen of the bladder,
inside the bladder itself,
that need to be checked by camera, so to be able to tell is it a stone or not. But the calcification in the wall of the bladder needs further scanning to tell exactly what the nature of that. I'm assuming from her description that's bladder stone. When they come to see me myself, I do a camera examination of the bladder from inside, and according to the finding, we can discuss it with the patient what treatment option is.
Now, this lady says she has a leaky bladder. She's 47 and her bladder leaks. She's been to the Lee Clinic in Cork. She says her pelvic floor muscles are perfect and she was given a pessary ring, but it hasn't helped. The Lee Clinic told her she's too young for surgery. What can she do? It's very embarrassing.
Again, the difficulty here is that this is, I suspect, more a gynecological than a urological problem. The pessary she's talking about is something to literally hold the womb in place. And I know that speaking to my gynecology colleagues, they're reluctant to operate on younger women. By younger, we're sort of under 50. The reason being that their concern is that they could operate and do a pelvic floor repair now, but that 5, 10, 15 or 20 years down the line, the woman might need to have the repair done all over again. And they're looking at other ways of trying to control it without resorting to surgery.
Yeah, when I explained it earlier by the storage part of the bladder function that need the bladder to relax and the sphincter to be tight closed. If you are leaking because the bladder is contracting, that overactive bladder. If you're leaking because the sphincter is not tight enough, we call that by stress leak. In her description, it sounds to be the muscles are a bit weak because of the prolapse and other problems, and that seems to be her story. And yes, treatment for this condition by the gynecologist in a young age group is a bit of reluctant really or difficult because it can be changed in multiple times.
Yeah, so she probably needs to go back to her gynae.
I would say so.
That's it,
need to go that,
A listener says she's 67 and has an overactive, irritable bladder. She's had urodynamic testing done and the bladder capacity is 150 mils. She's had treatment with tablets, but it hasn't worked. And she's wondering, what would you say about Botox treatment?
This is a very small bladder capacity to start with. And if that confirming urodynamic, the Botox and the medication might not be really the best treatment in here. What usually we do for these patients after a more further workup is we make their bladder capacity a bit larger by adding part of the bowel into the lumen or the wall of the bladder, what we call by augmentations. It's a good, very difficult decision to take really, but that's a treatment might be in need for. So I will advise again to go for a specialized female urologist to get that workup and treat it accordingly before she get committed to Botox injections. Yeah.
And just one final one on this, because we're out of time already, but a 90-year-old male has a PSA blood result of 4.0, and he's wondering, is this okay for his age?
Not to worry. No, the reality is that for all men, as we get older, our prostates get bigger and we produce more PSA. That would be considered a very normal PSA reading for a 90-year-old man.
Very good. Eamonn, before we finish up, there's just a lady, this is nothing to do with the bladder, but this lady just sounds a little bit concerned, so I might put it to you. She's in her mid-50s. She's feeling very lightheaded for about 4 days, especially if she bends down to pick something up. She's getting dizzy. She says, could it be stress? I run my own business and I'm under a lot of stress.
So, it sounds very much like a thing called postural hypertension. She's just getting low blood pressure, or she has low blood pressure, so when she puts her head down, there's a change in pressure of the head. First and foremost, I look to see if she's taking any medication of any sort. Secondly, something I'd encourage her to talk to her own GP about. Very occasionally, what I'm finding is that some people are not taking enough salt. Now, that's counterintuitive, because I've been telling to everybody for ages and ages, cut salt out of your diet. But for some people, they actually need a small, tiny amount of salt in their diet, and that brings up their blood pressure and the problem goes away.
Yeah, okay. Just one thing before we finish up, just to come back to yourself again. You mentioned about Irish people not drinking a lot of water. I think maybe the younger generation, the millennials coming up, are better. You see them going around with these bottles, big bottles. Yeah. What about the people of my generation and older, the women who drink tea constantly?
Yeah, that's one of the funny things of my clinic. I all the time call it by the tea race. So when patients come to me saying that I'm peeing a lot, I go to the toilet all the time, I leave the tea question to the end of it, which I like to make a laugh of it. And then I ask him, do you drink tea? Yes, I drink tea. How much cups? So the largest number I have so far is 16 cup of tea a day.
16?
16. And if you multiply that by 350, which is mugs, not cups.
Mugs.
Yeah. The problem with the tea is the content of the caffeine. The body lose or regulate the loss of water access through 4 pathways: sweating or breathing or with the back pacification or the urine. And he determined which pathway depending on the body temperature, exercises, whatever. When you drink caffeine, when the tea, coffee, other things, it will ask the body to produce large amount of urine and to be lost only through the urine pathways. So you'll be urinating more. And the problem with the tea also, it's a volume liquid. So when you drink too much tea, you don't have a space to drink water. And unfortunately, we do have a belief, hydration. Are you well hydrated? Yes, I drink a lot of tea. That's not hydration. Hydration means water. So if you're doing that yourself, then you need to cut down the tea too.
That's terrible. I can't take that at all.
So the equation we use is either UT or UP. So there is
UT or UP. Okay, on that lovely note, we let you go, Dr. Taha. Thank you so much for coming in. Lovely to meet you again. And thanks as always to Eamonn.
Next week, please, God. Yep.